treat patients with depression and anxiety in health settings. And quite honestly, this is actually really expanding. If you were going to ask me for sort of a almost more current definition, I would say that it's really any behavioral health condition that can be measured in a healthcare setting. So now we pretty routinely talk about ADHD, PTSD, bipolar, and some other substance use, opiate and alcohol addiction. So really thinking about all of those as the ability to be included in collaborative care. So when we think about collaborative care, we know that collaborative care is actually about putting a system in place to be able to care for a behavioral health population. And so when I think about collaborative care, you know, the original research, collaborative care came out of a research trial, late 90s, early 2000s, that for the first time really identified and treated a behavioral health diagnosis in primary care. And as we've continued and morphed, it's become collaborative care. There's well over 100 randomized control trials now that support collaborative care. And there's a ton of articles that support collaborative care outside of randomized control trials. And so the research is definitely in. And one of the things we know is that if you put a system in place to really monitor a population, then you're going to get better outcomes. And that's exactly what we saw. So collaborative care was recognized with dedicated CPT codes by CMS in 2017. Since that day, it has become a Medicare benefit, and then of course recognized by Medicare Advantage. And then now all of the commercial plans, virtually we have not had a commercial plan in a long time in any of the states that has not recognized collaborative care. And for some of you billing and administrative folks on the phone, then also know that the codes were auto written into your contract. So you don't actually need to do anything different. They're already there. You can start billing. We're now up to 34 states that have the codes added onto the fee schedule for Medicaid. Unfortunately, the states have all done something that looks a little bit different. So I'm going to try to be mindful of the states that I saw when I was looking through the chat quickly. The next state likely to approve the codes is going to be South Carolina, which is going to happen in October. I'm really excited because that's my home state. However, probably you might see Louisiana and some others sort of follow suit. I saw someone from Florida on the line. So Florida, it passed the budget, but has not actually been finalized yet. So there is some hope for our friends in Florida there. But one of the things about the Medicaid fee schedules is that there are different ways that some of the billing is done. For some of my FQHC friends on the line, then the states really made some different decisions about the codes that FQHCs would use. So I'll talk about that when we get to the codes. So again, just level setting in terms of what collaborative care is. So one of the things we know is that collaborative care is a monthly case rate. It is not billed by the session or by the contact, unless you're in California, and we should probably talk a little bit separately if you're an FQHC in California. But collaborative care adds 2 people onto the primary care team. So we have a behavioral health care manager that gets added to the care team. Lots of questions always about this person. This person, according to CMS, does not have to be licensed. However, there are some states that do require licensure of this person. I generally say the best person for this role is really someone who's master's prepared. Because you have a monthly case rate, and this is also important for our billing and coding folks on the line, it is a monthly case rate, but the collaborative care codes are primary care codes. They're not behavioral health. So when we add this behavioral health care manager to our team. This is not someone that has to be credentialed with the plans or appointed because they're not the billing provider, even though they routinely have contact with the patient and they are identifying and treating a behavioral health condition. It's actually done under the primary care provider as the billing provider. So interestingly, many of the contacts with that patient are by phone. Collaborative care was done telephonically way before it was even fashionable. And that's because it is very high contact monthly case rate. And one of the things we know is that having frequent contacts with people better engages them into care and gives them better outcomes. And so this behavioral care manager is actually really working with that patient pretty consistently, communicating with the healthcare provider pretty consistently and documenting in the EMR. So one of the other individuals that's added to the care team is the psychiatric consultant. So in collaborative care, that psychiatric consultant doesn't see patients and they don't prescribe medications. They actually meet with that behavioral health care manager once a month, talk about people that aren't getting better, are getting worse, and then make recommendations to that healthcare primary care provider. And that provider is the billing provider. So they are the ones also that are the prescribing provider. So they would be the one who would be prescribing and managing the medications with consult from the psychiatric consultant. So also required by collaborative care is a registry. And a registry, there's about 2, maybe 3 now EMRs that really meet the requirement for a collaborative care registry. Epic certainly does, MedEnt does, some of the others are working on it. There's a couple of options for registry outside of your electronic health record. There's certainly some Excel sheets floating around and some people use. However, there's from the AIM Center has the care management tracking system that's available. And we can send you some information on that if you're interested. And also organizations like Mira as one that provide a registry or have that registry function that you can purchase from them. So a couple of interesting things about collaborative care is that monthly case rate really allows collaborative care to be very flexible and to really provide very, very patient-centered care. So you heard me talk a little bit before about patients who aren't getting better or getting worse. Collaborative care is treat to target. And treat to target means that we are measuring outcomes and we're using tools like the PHQ for depression, the GAD for anxiety, the Vanderbilt for ADHD, and we're essentially looking for 50% or 10-point reductions in those scores in the first couple of months of treatment. And some states have actually been prescriptive about that, like New York as an example, that has that for 70 days. And also tools like the PCL for trauma or the PMQ, patient mania questionnaire for bipolar. And so very treat to target. So looking for that 50% reduction in the score, and then also making sure that someone then becomes subclinical, i.e. below 10, and in remission. So ultimately, we really want to get scores like the PHQ or the GAD down below 5. And so when we think about collaborative care and having the flexibility of being able to use that monthly case rate to really be patient-centered, we have a couple of treatment choices that are really key to collaborative care. And it's one of the most important things for care managers and organizations, leaders to really understand. And these choices, people can be in one or all of them, and they can change from week to week. So the first is symptom monitoring. So maybe we're just talking to someone, maybe twice a month, really asking them questions, monitoring their symptoms. I kind of think of this as a little bit of the lower level of care in collaborative care. And sometimes this may be all that people will really engage in. And so I let them know, hey, it's really important that your provider know how well you're doing. We have a way to measure, like we measure your sugar or your temperature when you're sick. And so I'm just gonna, if we could just set a time when maybe we could talk once or twice a month so that I could let your provider know how you're doing. And just doing that is enough to have someone in collaborative care as long as you meet the time frame for the codes, which we'll talk about. Medication adherence or support, someone does not have to be on medications to be in collaborative care. That's actually kind of a myth. In fact, many people are not on medications, like adolescents that you see with anxiety or maybe pre and postpartum women. So really helping people support their medication needs. And one of the things is to really say, hey, it's really difficult to take medications every day. Tell me about the times when you're not taking your medication, or let's talk about some times when you maybe take too much or too little of your medication for a particular reason. So helping people around medications. Behavioral activation is probably the one I use the most often. Many of you may refer to this or have heard of this around goal setting. So what's something you might do today or tomorrow to help you feel less sad? And then we set a goal and I give you a call to follow up. And maybe I do that several times in the first 2 weeks of care. The next is talk treatment. And so this is something that looks a little bit more like traditional therapy. Maybe we're meeting every week. And sometimes I'll say to someone, listen, it seems like you have a lot going on. Why don't we schedule a time to talk a little longer next week? And that person is in talk treatment, but maybe just for that week. Generally in collaborative care, only about 10 to 15% of your patients are going to be in talk treatment. So if you have more than that in sort of talk treatment, then you're likely in what I call the drift, and you've kind of drifted back to something that looks a little bit more like traditional care. So there are financial implications for the treatment choices.
Berna,
So
I'm
for my
sorry to,
financial friends on the line,
There's a question in the chat from Mary. PHQ tools were
uh,
validated.
yeah, I did see that. I was actually going to go back, but we can take it. PHQ tools were validated as screening tools for further clinical diagnosis assessment. What is the evidence for using this tool as an outcome measure? So there's actually lots of research out there that supports the PHQ, the GAD, as both tools and then validated measures for ongoing symptom monitoring. And in fact, some of the organizations, CMS is looking at it now. I've had conversations with NCQA that actually are going to change their language so that you're really using them because some of the language now and some of the quality measures depend on or have the language that these are only screening tools, and the literature doesn't support that. And so there's lots of research out there to be able to do that. And certainly glad to share it. Again, for those tools, it's ages 12 and up that the research really supports using them for ongoing measures. So thinking about some financial implications for the treatment choices, yeah, we can absolutely send some articles. It's pretty consistent out there in the literature over sort of a longer period of time that talks to that. So absolutely glad to do that. So when we think about financial implications of treatment choices, we really want to think about, so you heard me talk about the drift and going sort of towards more traditional treatment. So if you're doing more talk treatment, then you're likely spending more time with people, and that can take you into some uncompensated care. Generally, it's about 2 hours of care a month in collaborative care with all of the activities that are billable, and we're going to talk a little bit more about what those are. Also, not engaging patients and having them not engage in care certainly is problematic because you're not getting enough time to be able to bill for that month. And so oftentimes not letting people know that symptom monitoring is a choice, and not front loading, not talking to people 2 or 3 times in the first week or two of treatment actually really impacts engagement. And oftentimes you wind up then with episodes that you're not able to bill for that month. So a little bit more about the staffing. So CMS again doesn't require licensure, but someone needs to be able to provide all of the treatment choices. People will often ask me about nursing versus behavioral health providers. So nurses actually make wonderful care managers. I have many friends. In fact, when the research trial was initially done, it was all RNs and not behavioral health specific providers. I think the key becomes for an RN in particular, they tend to be more expensive than some of the behavioral health providers, and many practices have other things that they need an RN to do outside of collaborative care. So that would be some of the reasons. Master's level versus clinical social workers. Someone does not need to be independently licensed for this role. And in fact, you're going to likely pay a little bit more money. I was talking to a practice today in Pennsylvania, and we were talking about the model of having a student, a master's level student, and actually have them see patients and then work themselves into a job, so to speak. And understand at what caseload you're sustainable. I worked with a practice in New York today, understanding at how many patients were they self-sustaining or breaking even? What does that look like? And because this is remote, then someone can cover multiple locations. So you could centralize them and then they could actually be in multiple locations. So when we think about optimizing, oftentimes people will ask me a little bit about screening codes. And this has come up quite a bit. It actually came up at a meeting yesterday with some payers from around the country. And we really want to have you optimize your screening. It is revenue that you wouldn't necessarily be getting otherwise. However, it is a little bit complicated to use this code. It is only for screening many of your commercial patients. Medicare has some separate codes, the G044 as an example, or some of the states have some different codes on their Medicaid fee schedule. Technically, you can bill this 4 times during a visit, but there's literally no commercial payer that pays that. One of the barriers with using this code is that many of the commercial plans reimburse it at different rates at different cadences and have different requirements such as a monitor or a modifier rather. So really something to think about. We're glad to help you do it. So I like to put it up there. One of the things to know is that the care managers cannot bill for the screening tools, even though they're the ones that are actually doing them most often. One of the things we hope to change with CMS is to change that, but you have to be a prescriber or billing E&M codes so that you can do that. Celine, I see you had your hand raised.
Yeah, this actually just came up because we typically have our care manager, like, make sure we have updated measures before a pediatrician is seeing the kid in the office. And the pediatrician, like, and I'm going to talk to them about it, was like, I don't need you to get it right before they see them. And I was wondering if it's because the pediatrician is going to bill this, like if the patient is in collaborative care, can the pediatrician still bill the 96127?
So they can only bill the 96127 if the tool happens during their visit, right?
Right. And I think
And
that's why they were asking the care manager not to do it, because they were like, "Well, I'll do it and then
well,
bill for it."
so you could do that 2 ways. So there's a couple of workarounds around that is when that patient comes in, assuming the patient is coming in to the practice that day, sounds like a peds practice, then what the provider could do or the front desk, arrives that patient, that encounter could get opened as the care manager. I could complete the PHQ within that encounter, and then the primary care provider pediatrician could actually then attach the screening code. So that's a way often that it's done to
Okay.
be able to sort of, I'm going to say, get around that. also reviewing it, the time and complexity. But if it's going to happen the same day, then that's often why it's done in that pediatric encounter. The thing about it is then the care manager, if it's going into the time and complexity and getting counted on the pediatric visit, then
They
the
shouldn't
time.
count it.
Exactly. So then the time I'm doing it, right, shouldn't count on my collaborative care episode. And to be honest, a lot of practices say, screw that $6, right? It's not worth
Right.
the nightmare, to be able to do that. So you kind of have to make that decision. But
Okay.
that's often why they do that. And one of the things we're hoping to do is to change it, change that requirement. The problem is that they wouldn't add it to the monthly case rate. So we'd probably be right back where we started.
Okay, thank you.
Yeah, no problem. Thanks, Selena. So I wanted to just go through the codes a little bit and talk about what it looks like in, and answer some of the questions around the codes. So the 96127 for professional versus facility, no. The CPT code is the CPT code. So, the requirements are the same. If anyone's going to be billing collaborative care, professional versus facility locations 19 or 22, then CMS actually made their guidance a little clearer, and we can kind of do that with you offline. So just going through the codes and calling some things out, many of you are probably familiar with the codes. So the 99492 we have as our first month. Couple of things to call out. This is 70 minutes, right? Notice here that outreach and engagement is included in this CPT code and not included in the subsequent months. So if I'm calling Victoria and she doesn't pick up, I could count that time in month 1 and not in month 2. So really just thinking and calling that out to folks. Month 2, the subsequent month is 60 minutes, right? So continuing care. And then the add-on codes is each 30 minutes in a calendar month. Most payers, including Medicare, only pay for 2 of these in a given month. There are a couple of payers that pay unlimited. There's some like United that will pay if you, send in some documentation. But for the most part, you want to figure that there's going to cover 2 99494s. There is occasion when a claim will get denied if you put more than 2 494s. Sometimes they don't pay them. Sometimes they deny the whole claim. So you might have to play with that a little bit. But generally, you're going to want to stick to 2 here. And then there's the general BHI code, the 99484 technically is not part of the collaborative care codes. However, I sort of use it as the code of last resort. So it has to be at least 20 minutes, but sometimes, maybe at the end of the month, you might not make any longer than that, but you really don't use it that often. And here's, for many of you are familiar with CPT guidance and the 1/2+1 rule, which means that if the CPT is for 99492, the guideline is 70 minutes, then technically at 36 minutes, I can bill. So for 99493, I could bill at 31 minutes. The key is I can 1/2+1 of 494, but only if I do full 492 or 493. 99494 can't be billed independently. It has to be attached to the claim for a 492 or 493. So just keep that in mind for some of the folks on the line who are doing some of the billing, and important to remember that. So that for is something that can be used by other providers. Alina, go ahead, get your hand raised, or is it still raised from before? Sorry if I.
Sorry, I didn't put it down.
Okay, sorry, no problem. Just trying to be diligent here. I would say the 484 code, for the most part, that you're not going to use very often, and you do need to make sure you have that 20 minutes. What I would say is if there are codes, times when you're not getting paid for like management or some concrete services that use this 484 code to get paid for them. However, you can't do it in the same month that you're billing for collaborative care. So a lot of times we'll say, well, we can't include social determinants of health in our collaborative care codes. Can we use this code to pay for them? And I say yes, but you can't do it in the same month. So that creates
Sorry, everyone. I think she was having some technical issue. She should be joining us shortly.
sorry.
Okay. 1 second, Varna.
A lot of times that sends implications. The are gonna be okay. Uh, TD, all of the billing codes and requirements, yes, absolutely.
Varna?
I have to and send it out to everyone. Yes, sorry.
Yeah, your voice is cutting out a lot, and are you able
Okay.
to are you able to
Here's
share
what
your
I'm.
screen?
Yep. Yep. Hold on. I'm gonna try something. Hold on.
Okay. So sorry, everyone. She's trying to connect back in. Technical issues today.
Okay.
Okay. Can you say something, Verna?
You can hear me now? Yes, is this good?
Yeah, better. Oh,
Okay, I've gone outside on my phone, so hopefully. So you'll just have to monitor the chat for me, so Gina, if that's okay.
sure. Do you want me to, are you able to send me your slides so I can put it up for you?
Yeah, I'm gonna try to do that while we're talking, but I'm just gonna continue to talk and I'll do that. I think we've gone through a good chunk of some of the slides, so I'm just gonna try to go and maybe we'll share them with folks.
Okay.
So, just talking about dual eligible. So, dual eligible, remember, if your state covers them in the Medicaid fee schedule, then you can bill Medicare and Medicaid as the secondary. There are a handful of states like Kansas that don't cover the codes, but actually will cover them for duals. So just sort of thinking of that. There are a handful of states that do not pay the 99484. And in particular, Anthem does not pay the 484. Going to get for you get paid if you have a lot of Anthem patients. They're not going to pay a 99484 code. So something to consider. So a couple of things when you're thinking about doing a pro forma for your Medicaid rates, you'll know them locally because those are available online. Your commercial plans are going to pay exactly what you're contracted for in terms of your Medicare rates. So in other words, if you have a commercial contract and it pays a percentage Medicare, then these codes are going to actually pay that same level providers.
Verna, you're coming off and on, and we're not able to hear you properly.
You mentioned, we mentioned no social permanence under the collaborative care codes. And so for time-based inclusions, these are the things that actually count towards the time. So we need to talk about registry. So updating your registry counts towards the time, but inputting into your EMR does not. So people will often say, well, what if my registry is in my EMR? Then that actually doesn't count. It's sort of considered administrative and updating your EMR. Time spent talking to the psychiatric consultant, but that only counts once. So if I'm talking to my psychiatric consultant and we talk about Victoria for 10 minutes, then it only counts once. It doesn't count once for the psychiatrist and once for the care manager. Any time I spend with the patient, either in person, on the phone, or video, anytime I spend talking to the primary care provider. So I'm going to try to predict a question here from my friend is that the primary care provider is going to include that in the time and complexity for their visit that day, where there's other codes for them. Their time and effort doesn't get counted towards the collaborative care minutes. And the same for the psychiatric consultant. You're not billing for them. You're covering the cost of that psychiatric consultant out of your collaborative care reimbursement. So those are the things that are included in the monthly time. Sometimes people will ask, well, can you bill for individual psychotherapy codes and collaborative care? So the answer is you can. You can't double count the minutes. So I could bill a psychotherapy code and collaborative care. The thing is that if you're going to bill both, you have to do both. And in my experience, that's really hard to do, particularly if you're starting collaborative care for the first time. So I wouldn't actually recommend it. And if you really need to do that, maybe because your state is one of the states that don't cover the Medicaid codes, then you're going to have to, and we can sort of help you and talk you through it. So I think those are sort of the summary of like the clinical and financial, billing and coding and some of the things that you need to know. For those of you who are starting on your journey, I will say a couple of things. One is that collaborative care codes see very few denials with them. Once you get it down and billing that monthly case rate and using the last day of the month as the billing date, you're probably going to be fine. Some of the biggest problems for implementation and financial sustainability and really having a successful service line is the number of patients. And going to that land, people have heard me say the land of perpetual launch, not engaging enough or enrolling enough patients, providers not understanding it, not getting up to a full caseload, which is for a pediatric collaborative care managers about 75, for adults or others is about 90. So I really tell practices 30 patients the first month, 60 the second, 90 the third, so that you can be up and running. For my billing and coding friends on the line, generally practices with the average payer mix are self-sustaining at sustaining at like, month two. So I'm going to stop there. I know this was a ton of information. I apologize for the connection problems. I'm kind of in the rain under a thing here of trying to get the best service. So let me, Sujina, any questions or any raised hands, and then to remind everyone that we're available to help you, particularly with the financial sustainability pieces of it and to help you get some of those bills out the door. So if you want to have separate conversations around your state or your particular organization, then please reach out to us. So Sujina, I'm going to turn it back over to you for questions.
So far, no questions. Are there any from the audience that you want to ask Verna?
I know this was a lot of information and likely a little bit overwhelming. So like if you take it back and you digest it and you want to come back to us, and we'll share these slides along with the recording and then some additional information, the cheat sheet and some other things that were asked for with folks. That's not a problem.
There's a question. Does entering into CoCM requires additional patient consent? What does that look like?
So the feds actually learned something from chronic care management in that you don't need written consent. So likely CMS will change the requirement that the primary care provider has to get to consent to anyone on the team. But right now it's the primary care provider, and that's generally met by putting that referral in the chart. The assumption is that they've spoken to someone. Oftentimes practices will have them document or check something that they've obtained consent, and then they put the referral in the chart. And once they put that referral in the chart, then the clock can start for collaborative care for the minutes. And for some of my friends on the phone who are FQHCs or RHCs, interestingly, CMS was not actually kind to FQHCs. We're really trying to do some advocacy now and require them to use G codes, G5, G0511, and G0512 for collaborative care. We can send that guidance out to you. There's a really nice guidance document. And states did very different things. Some of them required the G codes. Some of them said use the CPT codes. So some of it is very specific. And unless you're in Montana where they carved them out, then, you have the ability to bill if it's on your state Medicaid fee schedule. But hopefully that answered the question around consent.
One question, where's the list of states that have Medicaid approval for CoCM?
In Verna's brain, mostly, I do keep a list. So if you want to put your state in the chat, I could probably tell you offhand, but we can also share the list out. It changes all the time because states are changing some things or updating rates or, plans and different things like that. But we're glad to share it.
Yeah, we have Mary saying she's from Illinois and another one from Texas and DC.
Yep. So DC does actually cover the codes. They passed them recently, and we have the guidance for that. Illinois was one of the first states to pass it into law, but it took a long time for them to sort of get it working on Medicaid, but it is now. And Texas is as well. Texas actually is one of the places where they pay a little bit higher for kids. However, they are ironing out the FQHC stuff. So let us know and we can be helpful there if you're an FQ in Texas. But fortunately, all of those states actually cover the codes.
Georgia?
Yes, Georgia actually passed the codes about 6 months ago. The rates are around Medicare rates. And so it would be wonderful. And there's some support for building CoCM in Georgia. So if anyone's interested in that, then there's actually some groups that are trying to do it there.
Do you have to be a CHC or FQHC? So another question.
Absolutely not. You can be a private, any primary care provider or actually specialty provider. So even cardiology, I knew a podiatrist one time that was making a ton of referrals, although the payers wouldn't cover it, unfortunately. But any primary care women's health provider can refer to and bill for collaborative care. So it can be a private practice, it can be a hospital-based site, it can be an FQHC, RHC, or, any version thereof.
Any other question? Let me go back. Does billing from CoCM come into conflict if patient is receiving behavioral health and traditional therapy in specialty mental health care?
So then that would be a duplication of services. So if someone is in specialty mental health, they're not a collaborative care patient.
So Verna, we're finally able to hear you clearly. Maureen was asking if the last few slides is something to review again, since we can hear you better now.
It's possible. I'm a little afraid to do that just because I don't see that I have any more bars, but I'm glad to share them out. We also have office hours that we'll post so that people can call in, but I look through and I'm covered everything that was on those slides. So
And we'll share the slides with you all after this training today too. So
yeah.
Can prescribing psychologist be the consulting psychiatrist role?
In most states, no. That is, they are actually not able to do that, and it calls it out pretty clearly. And also, there are a couple of states where there's some considerations around nurse practitioners because the guidance actually says that someone has to have full prescribing practices or ability, and in many states that's not the case. And so oftentimes there's some considerations in having someone be a psychiatric consultant that's sometimes addressed in the state legislation or guidance around CoCM and sometimes not. But particularly for consulting psychologists, the answer to that pretty consistently across the states is no.
Any other questions?
Sorry.
Feel free to type it in the chat or also unmute yourself.
I have a question. I'm sorry, I wanted to go back to the question about what Verna said would be a duplication of care. The question was, does billing for CoCM come into conflict if the patient is receiving behavioral health and traditional therapy and specialty mental health care? So I, in my program, had a similar question just yesterday in terms of, like, for example, if our behavioral health consultant in integrated behavioral health is seeing a patient and collaborating with the doctor on, like, care for diabetes and helping this person to be more regimented with taking their medication. I was confused. Are you saying it would be a conflict if they are in traditional therapy?
It depends on how you're billing that. So if you're billing a health and behavior assessment code, then likely you wouldn't have a problem. But if they're billing a psychotherapy code, then that has to be the talk treatment part of collaborative care, which means it really has to be an arm of collaborative care. Because remember, collaborative care is the identification and treatment of a behavioral health condition. And a lot of times people get thrown off by that care management term or think it's a lower level of care. And it really is treatment. And so it becomes a duplication of services. CMS does not explicitly say that someone can't be getting psychiatric care. So a lot of times organizations will have people maybe getting stabilized and moving back to primary care and being engaged in collaborative care. So I don't think it would be a duplication if your person was working with them around, some health and behavior work and diabetes and medication support, depending on the code, mostly.
Thank you.
And you're going to get some commercial payers who won't pay, if they see someone is getting psychiatric care and collaborative care and, paying psychotherapy codes, as an example.
Any other questions?
Been some great questions. Keep me on my toes. Remembering all those states off the top of my head. Oy.
All right, I think we're good to go. Apologies everyone again for the technical.
I'm so sorry.
today.
Yeah.
But we'll make it up. We'll send you the slides and also the recording of this. If you would like to get the recording of this, please let me know and I'm happy to share that with you.
Right. And it's good we didn't jump back on because I've completely lost internet and just got a notice that my internet is down. So yeah, it's going to make for the rest of the day challenging. But I apologize, everyone.
Thank you all so much for joining. And we'll also send out a follow-up survey email to you all. Please let us know how you felt about the training today. It would be very helpful for us. And with that, thank you for joining and have a